Good evening and welcome to this webinar on job planning. My name is Tim Mitchell. I'm a College Council member and an ENT surgeon based in Southampton, and I'm delighted to be joined this evening by our experts on job planning, Beryl De Souza and Daniel Redfern. So we have an hour allocated for this webinar. We'll spend about 30 minutes going through some slides, and then there'll be the opportunity for you to ask some questions. But please put in your questions through the website or through the app as we're going along, so we've got those ready when we come to the question and answer section. This webinar has been very well supported. I'm delighted to hear that we've had over 100 people applying to access it, and it will be available through the college website next week. So I'm going to hand over to Beryl now.
Thank you, Tim. So good evening, everyone. So my name is Beryl De Souza. I'm an RCS SAS forum member, and that's why I'm sitting here representing SAS doctors and talking about job planning for that group of doctors. I'm a specialty doctor in plastic surgery with a specialist interest in education. So what I've done is I've divided the short presentation that I'm going to give you into these sections. So looking at the current climate, looking at job plans, preparing for job planning, the sort of problems you might face in job planning, looking at how appraisal fits in with job planning, and then from the discussion side of things, that will be time for you to answer, to deal with any questions that you may have. With regard to the current climate and job planning for specialty doctors, what's important to note is that some trusts are in financial problems, and so therefore this might have implication for your role and your job plan. And so looking at your terms and conditions of contract and having an annual job review is important, and linking in with your appraisal is important. And be aware that imposition of added things onto your job plan is potentially a breach of contract, and you might need to seek advice about that. What I do want to stress is the job plan is very individualized. It's all about you and what you do in the trust, and how you also strive to develop yourself with the work that you do. So what's in the job plan? So the type of activities that you carry out on a day-to-day basis, a weekly basis, or a monthly basis, because you might have to do work outside your own trust on a monthly basis. One thing that may be unique for SAS doctors is not all SAS doctors take on an on-call arrangement. And if you do, you might either be acting up on a consultant rota, or you might be on an on-call rota with the registrars. And so therefore, you would need to look and see how that fits in with your job plan and the actual number of PAs you do with regard to your on-call arrangements if they arise outside the time frame, and that relates after 7 o'clock, and that would relate to payment that you would get for the on-call arrangement. There are additional responsibilities that you might have within the trust, or external responsibilities outside the trust with other bodies related to the NHS with regards to management and leadership. And they might be arrangements especially for you with regard to extra PAs if you're doing work for the trust. But in all events, there should be agreed objectives with you and the trust. And you might be in a position where you're doing private and fee-paying work as well, and that needs to be fitted in into the job plan and must be stated in your job plan. And who does the job planning? So the job planning is done between the doctor, the medical management, and your clinical director in your department would be involved in that, would have to support you with what you're doing. And in some trusts, there's usually sort of a team that's involved with job planning, or job planning is done as a team with everyone involved, with consultants and specialty doctors as well. Some of the issues may be related to what is put forward by the local negotiating committee. And in the resources, you will find a link to what the local negotiating committee is all about. What I'll say now is that some of the slides I have will probably be duplicated, and Daniel will probably have similar slides, but it'll just reiterate what we'd like for you to take home with regards to job planning. So what are the recorded activities that you need to put on? So they're things like your direct clinical care, your supporting professional activities, additional responsibilities, and external duties that you carry out, which have been agreed with your department and the trust. So the things that you do related to patient care counts as direct care, patient administration. So organizing your clinics, organizing your operating lists would count as direct clinical care. So you would need to factor the time spent doing that. And then with regards to traveling time, if you're doing outreach clinics, if you're traveling to another hospital, that would also count towards direct care. You'd have to factor in the breaks that you have, and then the prospective cover if you're covering for clinics or on calls for your colleagues, and looking at what sort of flexibility you have and your location as to where you are doing your main work and where you have to travel to should all be recorded onto your job plan. If you are doing more than 10 PAs in your job plan, then you might need to have a separate contract. You need to give notice with regard to this if you're adding on extra PAs. And it's very rare that trusts actually pay for more than 10 PAs in this current climate. So what are the objectives? Now, you might have a whole host of personal objectives that you'd like to achieve when you're doing your job plan, but there will be constraints laid on with that because it depends on whether they actually link in and fit in with the organizational objectives. And so this is where your negotiation skills come in, and you'd like to decide what you can achieve and what is permissible. And again, I'd like you to have a look in the resources. There's an article on negotiation skills that you might find useful. And therefore, what you will be able to do will probably have to factor in, as a sort of combined arrangement that you have with your trust. And it might be that you might not be able to do something for this year, but maybe next year when you link it in with your appraisal, you might be able to take on something new which you'd like to. With regards to the objectives, it's whether you've got adequate resources and also whether there are changes to your responsibilities that you have or the departmental responsibilities. And bear in mind where you're heading with your career and what you're doing and what personal development plans you have for yourself. And this may change, or you might forecast it changing when you're doing your appraisal. For example, for me, what was very challenging over the last year was trying to fit in my educational personal development plan. I was trying to finish off a master's in education, and this was an ongoing project that I had because I started off, this was sponsored by Imperial College, but it started off with a postgraduate certificate and a diploma, but the more intensive year was the master's, and I had to try and see if I could fit in the extra time. So this would be very different and individualized for all of you. What do you need? What's your job when it comes to job planning? You need to show evidence. And for showing the evidence, it would be looking at a diary card, what you do on a weekly basis or a monthly basis, and trying to fit it in with the college guidelines and with your own specialty advice as to what you should be doing, and linking it up with your appraisal and looking at hospital data. And here I've put on check, whatever you're doing in the hospital is linked under your name. So you might be working alongside a consultant, but what you are doing might not factor under your name. So always make sure, if you're doing an operating list, that the work you're doing is under your name. If you're doing a clinic, you can actually record what is happening, how many patients you're seeing under your name in the clinic, although you may be working alongside a consultant colleague. And that's quite crucial, because that actually reflects your own activity. And like I said, that you might want to know what's happening in your trust with regard to the local negotiating committee, and this may this usually pertains to the number of SPAs you're supporting, PAs that you would have to do. And you can see on the right-hand corner of the slide, the SPAs would come under the training, education, teaching, audit and research, leadership roles, clinical governance, any other roles that you might want to do come on the SPAs not related to direct clinical care. And the external duties may be duties such as doing work for the college, or your trade union, BMA, or one of the other organisations involved with trade union-like duties, or doing work for the government too. Those are things that would factor. Now, there is no set rule, and what trusts tend to do is they probably have a minimum of one SPA, but if you are doing and you're able to do more than that with the job that you have, then if you evidence it and you show it, and you have a strong argument with your department and the trust, it may be that you are allowed to do more. The Academy of Medical Royal Colleges have stated that 1.5 SPAs is what they think, and the GMC support that too, is suitable for SAS doctors. But you're probably going to start off with a minimum of one SPA. So the sort of problems you might encounter with regard to your job planning is when you're not going to get the right number of SPAs, or you don't get enough direct clinical care work, or you're not being recognised for the external duties you're doing. And these are the sort of difficulties that you might encounter, and these are the sort of things you might preempt yourself before you come to your job planning, your yearly job planning exercise. So what happens if you don't agree? So if you don't agree, you might want to go on to a mediation. So before you go on to mediation, you might want to write to the medical director, having had a conversation with the clinical director in your department, the lead clinician in your department, and think about what you disagree on. And then if you get an agreement from your medical director, then that's great. Then it all stops and you go on to finalise your job plan. But if that doesn't happen, then you move on to an appeal process. And with the appeal process, there's usually the number of weeks. You need to know about the number of weeks involved, 11 weeks, and how you appeal within 2 weeks of the mediation. And for when it comes to appealing with regards to your job plan, you might want to involve your trade union, BMA, to assist you with this. But be very careful if you're thinking about moving to an appeals process. You need to make sure you have all the evidence. And so having all the evidence every year when you're doing your job plan is useful, because you can show your work over the number of years, and in that way that will help you. So what you do want to achieve is a win-win outcome. So trying to decide what's really essential, what you'd really like to do for this year, and what's desirable but may not be possible this year but next year is something that you would want to think about. So be assertive, but remember you're working for your trust, and so you want to try and reach an agreement. And so what is the checklist? So make sure you have the evidence, look at the PAs, look at where you're going with your SPAs, what would you like to do? Maybe you want to change. From 1 year you look at education, 1 year you look at leadership, 1 year you look at management, but that's the sort of thing you could be changing and using your SPA for, and making sure that you provide all of this evidence and you discuss this at your job planning. So where does appraisal work and fit in with job planning? So appraisal is also an annual process, and with your appraisal you normally have to give in at least 3 professional development keys, things that you want to do, and maybe you'd like to do that with regard to seeing how that would fit into your job plan. So looking at the objectives from your appraisal and seeing if that fits in with your job plan. So those are the main things that I'd like to say from the SAS doctor's point of view, but I'll let Daniel say, and Daniel will probably bring out any other differences that we have from the SAS doctors and consultants. So I'll hand over to Daniel.
Just before we move on, can I just ask you a question?
Yeah, sure.
Just pick up on something you said, because I'm sure there'll be some consultants watching who would have been a little surprised to hear you say that SAS doctors mostly have a 10 PA contract, because
yes.
Consultants are appointed to a 10 PA contract, so they have a full-time contract, but I would think most consultants probably in the UK, certainly most surgeons, would be on more than 10 PA. So are most SAS doctors on 10 PAs? Is that?
Yes, I think so. So I think it's very rare that you'll have more than 10 PAs, but if an SAS doctor is doing on calls, that would bring the 10 PAs. And so you have a whole range of SAS doctors doing mainly direct clinical care without on calls, or mainly just in direct clinical care with not much on an SPA front. So it's really trying to encourage SAS doctors to use the SPAs and look at different ways that they can do that. Again, it's in relation to the job appraisal.
Okay, well, we'll hand over to Daniel for a consultant's perspective on this.
Well, we've had a very good exposition there of the matters that relate to job planning, and you'd probably not be surprised to hear that the issues that relate to consultants are not very different than the issues that relate to SAS doctors. And this is largely because the terms and conditions for SAS doctors are based on the terms and conditions for consultants, but there are some small differences. Just to deal with some things that you may or may not have heard so far, these are widely abounded comments in relation to job planning. Job planning isn't an option, it is contractual. It will not end after Brexit because there's no indication that we're going to change terms and conditions after Brexit. So you may as well get on with it, really. This is what happens when you don't have a job plan. These things arise when people's job plans don't reflect the work that they are doing. So job planning is important because it is contractual, and if things are not in line with your job plan, then things can go very, very wrong. So it's well worth paying a bit of time, a bit of attention to your job plan, because it may be burdensome, but it's extremely important. So, differences between job planning and appraisal. I want to emphasise here that job planning and appraisal are effectively unlinked, and that if they are linked in your organisation by one means or another, then that is an unreasonable linkage to make. They are not performance management tools. Appraisal is a tool for your quality improvement, and job planning is a tool to use to set your contract out. Good appraisal, however, will usually inform job planning, and so it's a good time to actually link your job plan in time to your appraisal, because you'll be remembering what it was that you discussed in your appraisal. So this is the definition of a job plan, and I'm sure you can all read perfectly well. The points that I want to bring out from that are that it's time limited, it's contractual, it happens in advance of you doing the work, and when you've mutually agreed a job plan, it is binding by contract. It must occur every year as a minimum, so that's every 12 months you should have a job plan. I've had 4 job plans this year, largely in relation to many changes that are taking place in my organisation at the moment. There is no difficulty with that. If you get used to the job planning process, it becomes a very easy and very useful tool for you to develop your practice. It's been part of the contract since 1991. This slide shows all of the elements of your contract, and the items that are outlined in the red box are those that relate to job planning. So you can think of a job plan as something that defines the work that you do, which is ordained by your duty of care, and relates to your accountabilities to your employer and patients, and more generally, which takes account of all of the resources. And this is in support of the most important word, I think, in job planning, which is objectives. You should always go into job planning considering what your objectives are, and that should be the realisation of your professional development plan, which you've done during your appraisal, hence the importance of linking appraisal with job planning. I'm not going to apologise for saying objectives several more times. So what must happen and what may happen? The bracketed elements are things that may happen in a job plan. So you may be involved in group job planning discussions and decisions, and these are the sorts of things that are supposed to happen at the level either of your directorate or your division or your individual clinical group. Now, these are not binding to you as an individual, but most of you would find that some element of joint decision making as a clinical group would be useful to the goals of the clinical group as a whole. What you must have, however, is an individual meeting formally done with your clinical manager. And I emphasize your clinical manager. This is not your business manager. You should then be allowed a period to negotiate the issues raised at your meeting, or if you're in complete agreement, you would agree it straight away. Then a decision must be made, and commonly this is where the whole process falls down, because neither of you can actually agree with each other, and you don't want to disagree with each other, so you don't reach a decision. You do have to reach a decision. In a lot of trusts now, there's a secondary ratification process at medical director level, and that's where I come in, because that's what I do for my particular organisation at the moment. Once that ratification has taken place, there'll be progression to a final agreement. Now, you've already heard what will happen if you don't reach a final agreement, which is a mediated decision. That's perfectly okay, and I would ask you not to be afraid of that. If you don't agree or can't agree with your first level clinical manager, then it is reasonable for you to take it to a mediated decision, and I would encourage you to do that. There are fair processes that are set out within the consultant contract which allow those mediation decisions to take place within a certain format. And if you cannot agree a mediated decision, then you would go to an appeal decision. And again, you've heard from Beryl how that is done. So how do you turn this onus into an opportunity? The key element here is to centre the conversations that you have around the objectives that either you want to set or that the organisation wants to set for you. And the three key questions that I ask are, when do I do this, where do I do this, and how do I do this? Both how I actually execute the objective, how much of the objective I do, and how it is going to be measured. You've probably heard of SMART objectives, but I can never quite remember what SMART stands for, so I tend to go for when, where, and how. So focusing on objectives, objectives fall into different hierarchies. There'll be objectives that the trust holds, division holds, directorates hold, right down to the individual. And the question you need to ask is, how do the trusts or divisions objectives fit in with my objectives? And if you're negotiating on this, be sure that all the objectives that you are being asked to adhere to also apply to the colleagues in your group in equal fashion, or to comparable colleagues within your trust, and if they apply at all levels. So there's a bit of jargon associated with job planning. Here is one of the terms that is used, and that is work. You would think that is fairly straightforward. But work does not just mean work, it also means the travel that is mandated by the organisation for you between the sites that you work at. Now, most of you will have one designated site of work, and travel can mean travel between one site and another site, or travel to an alternative site of work that is not your main site of work. That is claimable time. As you have also heard, work includes administration, and the administration can relate to the administration of your clinical care or the administration of your non-clinical care, such as your educational activity. Work done is calculated in units called professional activities, and in the contract, one professional activity is equated to 4 hours occurring between 7 AM and 7 PM on Monday to Friday, except bank holidays. Work at any other time attracts a rate of 1 PA for every 3 hours of work done. So there are 4 categories of work recognised in the contract. The first is direct clinical contact. These slides will be going out with the information, so you'll be able to get your magnifying glass out to have a look at the list of jobs, a list of activities that I'm going to be doing later. Work on direct clinical contact does include a multidisciplinary team meeting. A multidisciplinary team meeting is direct clinical contact when it involves an active case discussion of a patient. There's some confusion over MDTs, whether they are clinical contact or not. The key rule is if there's a patient discussed within the MDT, then it's direct clinical contact. It also includes some work which is displaced. So, for example, retrieval of X-ray results or retrieval of blood tests afterwards. It's actually clinical work rather than administration. The administration in relation to DCCs is also included, and it excludes you looking through emails and other administration that is not related to your patients. Supporting professional activity covers a massive range of activities, which you can see here on the right. These activities include teaching activities and activities that relate to the management of your organisation within your own directorate and within your own practice. Now, most trusts have a list like this one on the right to help you work out which of your activities are supporting professional activities and which are not. Please also bear in mind that it includes the travel time that is associated in doing supporting professional activity across one site to another site. Additional NHS responsibilities are a little bit more difficult to define. They are generally responsibilities which you can't usually absorb within the time that's available for supporting professional activities. So these are wider roles, such as clinical leadership roles within a directorate, or roles at deaneries, or roles for the trust, such as a Caldicot guardian. External duties are work for other external bodies, which are agreed between a consultant and their employer. Now, it is important that these are agreed. These are generally remunerated either externally or at the employer's discretion. Some employers will actually remunerate in part. Other employers will utilise inventive schemes in relation to your annual leave in order to recompense you for the time you have to spend doing external duties. And this includes work for our colleges and also examining or national selection. So for the new consultant, you need to ask yourself, is my job plan equitable? Do I have the same kind of time allowed, the same kind of access allowed, and the same kind of core development time allowed as my colleagues? Is it true that a new consultant can do things without new resources? I would argue that if you're in a negotiation position, the answer to that would be no. Try to resist downward pressure on your supporting professional activity. I'd refer again to the AOMRC statement, which not only supports the amount of time required for SAS doctors, but also for consultants, where 1.5 PAs is regarded as the minimum that would be required for a consultant to adequately execute the responsibilities required for adequate appraisal and revalidation purposes. In addition, it is reasonable to argue, and some trusts do take the position, that you need a little more time in your early years development as a consultant. And please don't forget travel time. So before you start, get ready. Read the relevant documents. Read the Royal College of Surgeons guidance. Insist on a written copy of your contract and insist on an indicative job plan before you start. Too often, consultants go into situations where they don't have a job plan 3, 6, 9, even 12 months down the line after starting as in their new post. So please do that. Your local negotiating committee will also have documentation that relates to job planning. Please make sure that you have read that. Look out for local variations to national guidance. Look out for local linkages between job plan and appraisal. They are strictly not on. Look out for the trust requirements in terms of their mandatory requirements for you to progress, any updates from your trust, and look out for flexibility in your job plan where you exercise it because you're a good surgeon and you want to get things done. You may be asked to do stuff that isn't actually within your job plan. You need to be careful that that doesn't become custom and practice. And take account of departmental job planning elements. A little point on joint job planning, it must apply to everybody. The clinical director will generally lead there and it focuses on the unit. But in addition, it typically includes the business managers as well as the clinical director. But remember, your job plan is ultimately individual and between you and your clinical manager, not your business manager. Common areas to look out for are issues where things can go wrong. Look out for all of these. Doing waiting list activity or practice if time is fixed in your job plan is strictly taboo. Counting teaching that occurs during a clinic isn't on. Not turning up to stuff that you say you're turning up to, not surprisingly, that is not on. Annualisation is quite useful for surgeons, and I would just spend a minute or two thinking about this. Annualisation only really considers your direct clinical contact time, and it's based in most organisations on something called a productive year. For most trusts, a productive year is 42 weeks. If you multiply the number of direct clinical contact requirements by the number of weeks that you do, times 42, you get an annual number of PAs that you might be required to do in the course of a year. If you do your work in this way, then it offers you quite considerable flexibility in terms of your ability to do other things. So if, for example, you do a 1 in 7 on call, you would probably consume as many as 110 PAs in that, which would leave you with a residuum of about 200 PAs to be spread through the remaining 35 weeks. Most surgeons work long days, so this would equate to working 2 or 2.5 long days a week for about 2/3 of the year, which allows you free time in the remaining time to do other activities. Condensed hours is a mutual agreement to condense your job plan, including your sport and professional activity, into a shorter than normal working week. It usually involves working some long days and having some non-working days, and it could be suitable if you and your partner are both doctors. But do look out, because it does mean that you have to take a pro rata annual leave limitation. So finally, get ready, do the reading, keep a diary, book as much 7-day activity in your job plan as possible. That might be the way that contracts are going at the moment, so do think about that. If you're concerned about a job plan change, request a review period. It's not unreasonable to say you will agree to something, but only for 3 months or so. Do concentrate on objectives, there's the O word again. Concentrate on the facilities that you've got. Remember your travel time. If you don't understand it, ask your LNC or your industrial relations officer through the BMA. Keep your eyes open. There is my diary. The very best of luck. Thank you.
Great, thanks, Daniel. This is probably a good opportunity just to say to those of you who might be at the point of applying for consultant posts that there is a process by which the college approves new consultant posts. It's not mandatory for a foundation trust to subject job plans for consultant job descriptions for college approval, but if they have been and they've been approved, you will see the college logo on the advertisement and on the paperwork that goes out with it, and that's very important. It means that a consultant in your specialty in that region has gone through the job description in some detail, and it meets the clearly defined criteria for approval by the college. So we'll now move on to the question and answer section. What I can say is that if you wish to alter the split in the screen, you can do that. So if you want to see more of us and less of the screen, you might want to do that at this stage. And do we have any questions that have come in so far? Okay, so the question, what is the difference between clinical managers and business managers? Beryl, shall I pass that over to you?
Okay, so a clinical manager is a medic. So it'll be your surgeon who has a manager role, and your business manager will be a trust employer, usually someone related to the HR department or someone involved in the directorate. And so the two of them are involved in your job planning. So, but your clinical manager will have knowledge of your department and what's happening in your department, and will be the one to sort of scrutinize what you're actually doing with two hats on, with a clinical hat on, knowing what you're doing, and with the management hat on, looking at the feasibility, what's available for the trust to actually recommend and approve what you're doing. And your business manager obviously has a sort of a management HR role to say, well, you know, is this actually going to be feasible for you to do, especially when it comes to, I think, from your SDA side of things. I don't know whether you'd like to add any more to that.
Yeah, the clinical manager is generally a colleague in the vast majority of cases. Yeah. I say no, over 90% of cases will be a colleague chosen within that department to actually lead the department from a managerial point of view, and they will do the majority of the legwork in relation to your job planning. The decision then, once made, will pass to a business manager to actually execute the, as you said, the human resources elements to it. But a business manager might be involved if you were to get into directorate-based joint job planning as well. But actually, in terms of an individual job planning role, that sits with the clinical manager still, and that's the best practice in the BMA NHSE guidance on the matter. Did we go past the question? Do we go?
So in a sense, it's slightly curious, isn't it? Because this is a contractual process, yes, and yet it's done between two doctors and not actually with the hospital management directly. There's obviously a requirement that the management requires it to be done by its staff, but actually the contact and the agreement, assuming there is agreement, is between two clinicians. I think that's the key thing. Isn't it?
It is. They do have, the clinical manager is a trust appointment to, as in a managerial capacity, and there are some clinical managers who will not be in your specialty. So there are some situations where that isn't the case. But I'd say over 90% of cases, it's a physician in your own speciality. I think we need to go back one.
No, forward.
No, forward. That's so our template's available.
So why don't you take that one, Daniel, then?
Our template, well, as you've just heard from Tim, the Royal College of Surgeons produces excellent guidance in relation to job planning, and I would recommend it is available, and it is extremely good. There are also model job plans available through the British Medical Association as well, but they apply more generically. The college output is actually relates to more specifically to surgeons, so you may find that more useful.
I think I was just going to add that the LNC in the trust will also have job plans available, so you might want to get in touch with the LNC, specifically if it's job plan for your specialty or your department, and your department can help too.
We've talked about documenting everything that you do. Many trusts are now using a computer-based program for doing that. Do you have experience of that?
Yes, many years. We were quite an early adopter in our organisation of doing that. It has its advantages and its disadvantages. Some of the systems are quite laborious and take quite a bit of getting used to, and not all of them have the kind of detail that you would probably want to actually describe some of your activities. But then most of them, if you raise the issue with your organisation to say that my activity isn't actually covered, we'll be able to actually put a new activity in there that would relate to what you do. But they are a little cumbersome until you get used to using them, and they take more time initially.
I have no experience of yes, well, that I still use the old-fashioned pen and paper.
Okay, another question. How lengthy is the appeal process? Well, Beryl, you touched on that to start with, so perhaps you'd like to say that.
Yeah, I think that there are time constraints for an appeal process, and my slide reflected that. So, and this is part of the legalities, and it may vary from trust to trust. And so if you are having difficulty with your job plan, if you haven't got anywhere when it comes to speaking to your clinical manager and your medical director, then you do have to look at and see where you go with the mediation process and where you go with the appeal process. Because if mediation doesn't work, then you go on to an appeal process. And so there are tight time constraints, and they normally happen within a 12-week period, as I showed on the slide. But you'd need to seek help from your trade union when it comes to that. So you'd need to get contact at the BMA and find out, because you will be supported by an IRO if you're going through an appeal process. But as I said before, if you're going through an appeal process, you need to have all the evidence to hand, and possibly your previous job plans and how things have changed, so you can use that as evidence as to why you are striving to get certain things onto your job plan.
I could add to that. It will vary between organisations. There is overall guidance actually within the consultant contract and within the best guidance for NHSE, and that's also been translated directly to the SAS contract of roughly 11 weeks in total. In my organisation, I think that's rather too long, and I've tried to actually speed that up a little bit just to make sure that people aren't hanging in limbo. But it will vary, so do look at your local documentation in relation to job planning. They will either have a policy or a framework that should set all of that out.
And you've mentioned that a couple of times, the consultant contract and of course the SAS contract, the equivalent. They are of course available on the web through the NHS employers website, and I think a very useful resource to look at least refer to when there start to become difficulties. And I think we should stress that this is not the norm. The vast majority of people will sign up for job plan quite happily with the person they report to, but clearly there are times when there's a problem, and then you do need to know exactly what the situation is.
And NHSE do tend to update their websites quite regularly, so that's a good resource.
So we've got a question here probably for you, Beryl, I think. Someone's been working as a registrar for 4 years, now been asked to take a specialty doctor post, but they're afraid that they will lose some salary because of the reduction on call commitment.
Okay, so so if you're moving, so this is something I did in a way as well. So if you're moving from the training post to the specialty doctor post, this is the time that you really need to look quite carefully as to how you're going to carry on your professional development and what you're going to do with regard to deciding whether you want to get onto the specialty register. And if that's the case, you might want to carry on with your on-call commitment, to carry on your training development. And so from a salary point of view, yes, you would lose out if you're not doing on-calls, because as Daniel had shown, if you're doing on-calls and you're working out of hours after 7 o'clock, then the hours you get one PA for 3 hours, and so you lose out from that point of view. But you might also lose out from a training point of view. So you need to carefully analyse what you want to do. So if you're someone who wants to get onto the specialty register, you might want to say you'd like to carry on with the on-calls, and you might want to fit in on the on-call rota either with the SPRs or with consultants. So this is something that you have to discuss with your clinical director. But think very carefully if you're moving from a training post to a non-training post, such as a specialty doctor post, because what would you like to achieve at the end of it?
I suppose underpinning this is possibly the concept of pay protection, which of course has applied to people in training posts and in consultant posts in the past, when there has been a change in national terms and conditions and a new contract has been imposed upon people. But this is a very different situation, isn't it? Because you've got someone moving from one contract to another, from one role to another. So that concept of pay protection wouldn't apply.
No, because it's a different. So when you take on a specialty doctor post, it's a different role altogether. But there are still grades in the specialty doctor post. So if you're a year 4 registrar, you would get onto the specialty doctor post, and you would need to see at what level you fit in. Again, you might need help from the BMA to look and to see what sort of pay protection, as Tim alluded to, you can get, because the level of your training would suggest you're senior enough to be at a higher level in the specialty doctor post, and you have to go through the incremental stages and how you would move on to the incremental stages. And this is where the on-call might be useful for you to move on to the incremental stages too.
Thank you. So this looks like one for you, I think.
Reasonable for admin time for full-time consultants. Right.
That's a piece of string.
It's a very good question. It's a very good question, and it begs an awful lot of other questions as well. So there are, and this is my personal take on it, there hasn't really been clear guidance. Initially, it was thought that you would have 1 hour of administrative time for each 4 hours of time that you spent doing clinical activities, but then it became clear that different doctors did different kinds of clinical activities that may or may not require administration. So for example, in anaesthetics, most of the administrative work that is done is actually done during the course of their work and not separately. So the requirement of administrative time for an anaesthetic consultant is considerably different to the amount of time required for, say, a surgical consultant. However, for those consultants who do have what I would call a clinical input, in the sense of the word that they have a group of patients that they are required to look after on a continuous basis, the activities that generally generate administration time are clinics and multidisciplinary team meetings. So that in ward rounds, you generally expect to get all your administration done during your ward round. During your theatre list or procedure list, you'll expect to do all of your administration during your theatre list or your procedure list. So for those activities, broadly speaking, somewhere between 0.35 and 0.5 of a PA seems to be reasonable for a consultant per activity that generates administration. That is only based on my own analysis of my own data within my organisation, but that seems to be roughly where it is.
And just to go back to your presentation, you presumably would draw a distinction between direct clinical care administration and non-care administration as well.
That relates to direct clinical care administration.
Yeah. And I suppose the other thing is that within a department, people subspecialties may have slightly different ways of working, but you might expect that broadly, certainly within the same subspecialty area, for people to be putting the same amount of time approximately. That would be a sort of sense check on.
Within a particular clinical group, you would expect those to be broadly the same. But I think actually even perhaps across wider clinical groups, it's difficult to see why there would be very big variations in terms of the administrative time. And usually where that happens is because people have actually misinterpreted, they've displaced clinical work into administrative time. That's generally speaking what's happened.
And whilst we're covering comparison, I guess for on-call, for instance, it's obviously logical if you're on the on-call rota with somebody with the same on-call commitment, you should be putting down the same amount of commitment. You would expect allocation for on-call, of course, and if you're not, then clearly that's likely to be challenged.
And that's something that I would be looking for in my sort of oversight role, to sort of check that is okay. What if this if I don't have a job plan? Well,
let's start then. We'll go across to Beryl.
Well, there are many. A job plan is your perspective. Everybody must have a job plan. That's a simple answer to that. So if you don't have a job plan, you should have one, and you should be able to ask for one, and you should get one within 3 months of asking for one. The disadvantage to not having a job plan is that you have an open-ended agreement between yourself and your employer as to what work you can and cannot be asked to do at what particular time, and in relation to the resources that you have available to do that job, and in relation to developmental time that you would or would not be allowed in relation to your job. So the disadvantages are many. If you don't have a job plan, ask for one, and you should be able to expect one to be done for you within 3 months.
Beryl, do you have any further comments on that?
As you said before, it's contractual, so it's really important to have a job plan. And so if you haven't got one, you have to ask for one. I think as an SES doctor as well, it's so important to have a job plan, because then it allows you to actually put down what you're doing with regard to your direct clinical care and your SPAs, and it really focuses on the fact that you do need your SPAs as well as your direct clinical care, and the actual variation of what you'd like to do from an SPA point of view. So it's dangerous if you don't have a job plan, is what I would say, and you need to knock on the door and keep asking for one, and have the evidence for what you're doing, because if you don't have one, then make sure you have the evidence for what you're doing on a weekly basis, because that will be part of the job plan that you will go on to get.
Okay, we're going to try and squeeze in a few more questions if we can. I think this one probably is for you again, Beryl. Are there separate requirements for associate specialist and specialty doctor posts?
No. So if you want to apply for a specialty doctor post or an associate, so the associate specialist post doesn't exist anymore. So if you come off the training program and you want a sort of service type appointment in a trust, a specialty doctor post in a specialty, then they are set contracts for that, and you can look that up. So there are no separate requirements, other than the fact that you should be well trained. So a specialty doctor is really a senior person, a senior trainee in that specialty. So there will be some essential requirements to take up such a post. So up to at least 4 years of training under your belt before you can apply for such a post is the main thing to get across. So the associate specialist post doesn't apply at the moment, although there are going to be changes to the contract. So the RCS doctors are opening the contract up and they want to reintroduce the associate specialist post, but that hasn't happened yet. If I've passed FRS, can I opt for any? Well, yes, if you pass FRCS, but you've passed FRCS you haven't really stated in that specialty. So if you've passed FRCS in that specialty, you're accredited, and therefore you can apply to be on the specialist register, which you can do through the CSER process if you're a specialty doctor, and so that is a possibility. So yes.
Yes.
Okay, so we're just going to say yes to that one, that we do maintaining the salary is very important, and all those things should be included essentially. We've got a few more questions to get through, so let's try and see how we can get them. How do you approach when a job plan request is not addressed by the department? Right, so you've asked for a job plan review and it has not been addressed by your department, then I would be going directly there to your IRO and your LNC, because that's a breach of the contractual. They are required to give you a job plan, so go straight to your IRO or straight to your LNC with that one. Is there a time frame on that? I just go straight out the next morning. Okay, they can do that straight. They cannot do that. Is the organisation obliged to have one at certain intervals, or I mean, clearly if you had one last week, it might be 3 months before you have another one. Is that? Any individual can ask for a job plan review at any time, and your framework within your trust should deal with when those job plans should take place, but it should be timely. Beryl, here we are. So there should be one for you. I think this would be fairly straightforward.
If I come at 7:30, which is right, should I put CP to start from 7:30? Well, if you're coming in at 7:30, so you're starting work at 7:30. So of course, yes, you would be starting at 7:30. That is work. So from the time you get in and you start work, not from the time you come in and have your coffee, but from the time you start work, that's when you start, and that goes down in your diary as your start time.
Now, Daniel's very hot on travelling time, so I'm going to add just a slight complexity. Of course, it might not be your base hospital that you're doing as operating this, in which case Daniel's going to say we need some travelling time in there as well.
Not only that, and if your travelling time actually takes you before 7 o'clock in the morning, that would be premium travelling time as well. So.
Top tips for securing a good job plan.
Right, go prepared is the #1 top tip, and have a diary. Have an idea of what it is that you want to achieve. So if you're a surgeon, you're going to want to know my operating sessions, my procedure sessions, my clinic sessions, and where they're going to be, who's going to be looking after me. But also don't forget what you need to support you in that job plan. So you need an office, secretarial support. You need the right environment to do your theatre. If you do my kind of surgery where you need to put in implants, you need the right kind of theatre. So don't get shoved into the little theatre with no windows and no ventilation. So think about your resources as well as thinking about what you want to achieve in your job plan.
Well,
I would say sit down and give enough thought to this. Maybe look at your appraisal and what your professional development plans were for that year and see how it fits in with your job plan. I would concentrate a lot on the SPAs and see if I can tick off all the boxes with the time frame. I would try and ask for more and then settle for less. And I'd urge you to look at that negotiation article, because if you don't ask for more, then you will always get a lot less, but try and make sure that you have a well-rounded job plan. We're talking about surgeons being engaged and not having burnout. So really speaking, look and see how you can be very holistic in your job plan with your SBA as well, with regard to research, teaching, audit, perhaps looking also at getting involved with patients in the patient groups in your hospital, things like that. Try and be innovative and inventive in what you want to do in your job plan, just to keep you keep you going and keep you enthusiastic with what you're doing in your specialty.
Can I just say the objectives again? Stick to objectives. Nobody can argue with objectives.
Thank you. Well, amazingly, we've come to the end of our hour, I'm afraid. I'd just like to thank Beryl and Daniel for their contributions. I think it's been a really excellent session. I hope you've enjoyed it. Thank you for your very interesting and sometimes challenging questions. You'll see on the screen there our next webinar is on the 4th of December, Interview Skills by John Brecknell. Those of you based in London will know him well. If you're up in the northeast, then next Thursday at the Assembly Rooms, we've got a day session on surgery and the law, which is free to members and fellows, and another event here in London, Prehabilitation and Perioperative Care Conference on Friday, 22nd of November. So thank you for joining us. Here's a list of other activities that are available for you to get involved with at the college. And don't forget that this webinar will be available through the website along with the other webinars as of next week.
I'd just like to say, as that flashed up, we're looking for more people to join the SAS forum. So this would count as college work, and this would fit into your extra additional work that you can do. So do consider applying. The closing date is the 5th of January, so you've got a lot of time to think about it, look at on the website, see what the SAS forum actually does, and get involved.
Great, thank you.